Cynthia, thanks so much for this invitation. I am an early signer on for the GP Optho, and first of all, it's a great idea. But as everybody who knows Dr. Cynthia Matosian knows, if Cindy's in, the rest of us are in as well. So
You're
tonight I'm
very
going to talk.
kind, Darrell. Thank you.
I'm going to talk this evening about diagnostics, and I think it's a nice way to lead into Dr. Reinerson's talk about one of the kind of key fundamental pillars of treatment of dry eye disease, working on the lid margin, removing debris, removing biofilm. And Dr. Reinerson is one of those folks who was an absolute pioneer. And, in many ways, we've all kind of been riding on his coattails. So it's a real privilege to be the guy who's going to lead into him. Today, I'm going to talk about the Hilco Vision Care Solutions, Bruder M&S technology consortium that got together and brought us the Bruder Ocular Surface Analyzer. I don't have control over my slides, and so I'm not going to try to be cute or any cute than I always try to be. And I'm just going to ask for the next slide, please. So this is me. I'm not nearly this impressive. This picture was taken about 30 years ago. As you can see, I'm also not nearly as young or as handsome as I used to be. So we got to get off this slide really quickly. Next slide, please. All right. The Bruder Ocular Surface Analyzer is kind of like the Swiss Army knife of dry eye diagnostics. It is an appropriate addition to a practice that is like mine, a tertiary care dry eye practice, because it allows us to automate and kind of objectifies many of the things that we're doing where it's really more stylistic. And this gives us lots and lots of consistency. It's also that one-stop shop diagnostic piece of equipment if you are trying to start a dry eye practice. It will get you launched much more quickly, and it allows your entire staff to really be on the same page. I love the title here, A Fast Objective Approach to Ocular Surface Diagnosis, because it really does give us objective data that will be the same every single time we do it. And that allows us not only for our own purposes to compare what we had before with what we have today, but it also allows our staff to have the confidence that they're giving us data that we can trust and that we can make decisions from. Next slide. So why the BOSA and why use it when we're treating dry eye before cataract surgery? This is really the hot dot right now in ophthalmology in the anterior segment. Making sure that you identify dry eye, identify every person who has dry eye or maybe is on the precipice of dry eye before you go forward with cataract surgery. This is our bread and butter. I mean, I talk about myself as a cataract and refractive surgeon, but there are actually very few people doing high volume refractive surgery like what Cynthia and I would remember and Dr. Reines would remember back in the 90s and the early 2000s. But we're all doing refractive cataract surgery. We all have the same expectations on our patients' parts for that brilliant outcome from cataract surgery, even if you're going to put in a standard lens, even if you're going to do a straightforward traditional phaco, not going to use femtosecond laser for any of part of it, not going to put an advanced IOL in, your patient doesn't really know that there's a different expectation. Your patient thinks that they're not going to wear glasses. And in order to get there, you have to have good data going in. So we identify dry eye preoperatively because that gives us better biometry. Lots and lots of studies done that show that if you have even a little bit of dryness, you can have both induced and hidden astigmatism. That crops up postoperatively, you're in a world of hurt. It can be hard to get just the basic keratometry if you have a significant dry eye. I tell folks that if they see one punctate staining spot, that patient has dry eye. If they have a tear breakup time, that's 1 second less than 8 seconds, they have a dry eye. The BOSA allows us to get objective measurements there. Dry eye can reduce the postoperative vision in addition. We know that elevated tear osmolarity increases light scatter. Well, there are lots of things that cause increased tear osmolarity. And the better we are at identifying the type of dryness, the more accurately we'll be able to treat the dry eye on the way in as well as on the way out. Don't forget, no matter what you do in the anterior segment, if you're going to operate on the front of the eye, you're going to make the eye drier. Cataract surgery, LASIK surgery, PRK, SMILE, the new EVO ICL, all of these procedures, no matter how well you did it, are going to make the surface of the eye drier. You're also going to have fewer complications. If you pre-treat the ocular surface, if you aggressively find and treat dryness, it's less likely that you're going to have things like a neuropathic corneal pain syndrome. Unfortunately, you can't prevent 100% of them. But the more you do to tidy up the ocular surface preoperatively, the less likely you are to have that. And it all leads to the holy grail, higher patient satisfaction. The happier our patients are, the more they're going to talk about how well we did, the more they're going to talk about our practice, the more they're going to talk about you, the surgeon, or you, the referring optometrist, who is the person who's going to carry that patient through following the surgery. Next slide.
Darrell, we have a question that just came in.
Sure.
You mentioned that your practice is a tertiary dry eye referral center and BOSA fits in well. Would BOSA fit in a comprehensive ophthalmology practice when they are not a tertiary center?
Absolutely. Absolutely. Again, I'll go back to my analogy that the BOSA is kind of like the Swiss Army knife of dry eye instrumentation. Everybody can use it. It's incredibly easy to be trained on it. It gives you consistent results, excuse me, and every single person in the pipeline bringing the patient into the exam room is going to be getting basically the same results. It's an efficiency driver for both the practice that's seeing early, mid-stage, and late-stage dry eye like mine, but it's also an efficiency instrument for that practice, which is a comprehensive practice, just picking up the dry eye that comes through the door on the regular day. You know, we're a tertiary care practice in that I see the 7th consult, I see the 15th opinion, but the majority of our patients are still people who are coming up through the pipeline in our own practice, and identifying them is just as important as helping that really weird, strange, unbelievably complex patient. And the BOSA works. The BOSA sets the stage for success.
Thank you.
All right, so let's talk about the BOSA as the big end of the funnel that is making us proactive in treating dry eye. One of the beautiful things about the setup and the software and how things are presented is it makes it super, super intuitive when it comes to educating our patients about the fact that they have dry eye and educating our patients about how we're going to treat it. Are we going to be able to do just straightforward pharmacological treatment? Are we going to put them on an immunomodulator, put them on a steroid? Are we going to put them on a medication that's going to reduce evaporation? Do we have to be more aggressive? Is the root cause of what's going on something on the surface of their eyelids? In a moment, we'll see some pictures, which I think will lead very nicely into Dr. Reinerson's presentation. If you show patients plaque on the surface of their lid, if you show them those telangiectatic vessels, they're going to know intuitively what you're talking about when you're talking about using a treatment to remove that. The pre-treatment stabilizes the ocular surface, improves the biometric accuracy. I know that I might have to have a conversation with a patient about treating their dryness before I'm actually able to take them to the operating room as soon as I see the data on the BOSA coming through on our EMR. Having the patient be able to visualize what I see makes it easier for us to get them to buy in. It makes it easier for us to get them to commit. Because let's face it, we are kind of like the offensive coordinators, right? We're up in the booth. We're looking down in the field. We've got our headset on, and we're telling the quarterback, we're telling the head coach what it is that's happening on the field. But at the end of the day, we're in the booth up top. We're not taking the snap. We're not throwing the pass. We're not making the block. The patient's going to do all of that. So getting them on board by showing them what we see, I think, is an important aspect and one of the big advantages of the BOSA. Next.
Darrell, does the BOSA have a printout that you typically hand to the patient to keep?
If you are a practice that utilizes that type of education, the BOSA can generate a report for the patient to take. Our practice has developed over the years internal paperwork and internal educational resources. So we don't use the auto-generated from the BOSA or frankly from any instrument that we've either used or trialed. But it's a really, really easy way to do that because it does get generated by the BOSA.
Thank you.
It's really, really easy to put this on the front side of your dry evaluation because you can generate lots of data that's going to populate the electronic medical record. And actually, anything that happens before the patient gets to the doctor is something that the doctor doesn't have to do or repeat unless there's a question. The basic dry analysis can be completed in about 4.5 minutes. You can get standardized testing protocols set up for different types of exams. You can have a pre-op cataract exam. You can have the intro first dry eye examination when the patient is new. You can use it for screening everybody who's coming through if you wish. And it's a great way to look for continuity in what you're looking for as well as what you're telling your patient because there are comparison platforms that can be used. Next. So let's do a little bit, just go over the pre-cataract ocular surface evaluation and how you work it in, just some blocking and tackling here. The initial evaluation in that evaluation, we will discuss our recommendations for the lens, but we may actually fold in the ocular surface testing in our office for the very first evaluation. We don't bring the patient back for an additional lens discussion because we often have that done in the referring optometrist office. And we're doing the heavy lifting from the ocular surface standpoint, but you can do it as separate visits. If you do a separate visit for the ocular surface evaluation and you use the BOSA and you review all of the results, you can easily justify a level 4 established patient visit 99214 if you have either spent the time or if you demonstrate the risk and the complexity of both the examinations and the discussions. You want to discuss the dry eye recommendations in detail. You want the patient not only to understand what they're coming into from a surgical standpoint, but you want them to know that it's vitally important for them to treat their dryness going in and going out. For a non-cataract patient, you can use this as a screening test, but you can also use it as part of an advanced dry evaluation. If we're using this as a screening test, either for an established or a new patient, that would generate a level 3 established patient CPT code 99213. But if you're doing a complex consultation, like my 17th opinion that I had today at 3:30 in the afternoon, I'm going to have lots of data that I can share with the patient generated by the BOSA to help them understand why it is that they've had 16 opinions before they got to me. Next. All right. So the BOSA reports on the BOSA software can give us lots of things that make it easy for the patients to understand. I love the daily report. It gives them all of what we found. It gives them tear meniscus. It gives them tear breakup time. It gives them oil level in one sheet. And if you have a color printer, which of course we all do, you can hand them that each time they come in. The Nick Butt binocular report is the one that makes the most difference for me when I'm talking about what a patient is suffering from that's going to affect their preoperative evaluation or their cataract surgery itself. We're looking for the first break in the tear film. Anything under 8 is abnormal. Anything under 5 is dramatically abnormal. But BOSA also gives us individual patterns on the cornea, which makes it easy to explain to the patient why it is that having dryness and having an early tear breakup time is affecting their vision. Meibography, the binocular report, if you show a patient obstructed meibomian glands, if you show a patient destroyed meibomian glands, the next part of the conversation is really easy. If you think that you've got blockade on the surface and you want that patient to have BLEFX, you're able to show them quite clearly where the disease is. If you have meibomian gland destruction, you have meibomian gland obstruction, you want to use some sort of thermal expressive technique, the patient looks at it, and before you're ready to start, they already know what they want. We get high quality photographs of this and it happens automatically. And then the change analysis report is actually brilliant because it can show the patient how well they're doing with the treatment, how it's progressing, how they're improving. Next.
Darrell, I think that last picture is very important because especially if it is a cash pay procedure similar to BLEFX that Dr. Reinerson will be discussing shortly, by seeing the improvement and the objective data, they have less hesitation to open their wallets and pay for those procedures.
I think that's a great point, Cynthia, and showing them that the more conservative stuff didn't move the needle is also an important thing that helps to promote that next step. We use much of this in our regular dry follow-up exams, but we definitely use it in our more expansive, advanced evaluations. Again, the automeibography, all you have to do is flip the lid. The machine does the rest. It outlines the areas of loss and calculates a percentage of gland loss. Some patients like the number, some patients don't. I find the visuals that the BOSA presents to be the most compelling for the patients. I like the automatic tear breakup because we don't have to worry about who's counting fast, who's counting slow. We don't have to worry about uniformity between technicians or doctors. It's always going to be there. It's always going to be the same. Lipid layer thickness is very helpful when it's low. That's easy to understand. When it's high, we have more of a conversation about skin oils and things like that. But when it's low, again, very impactful. The auto tear meniscus height, this has really driven up our usage for Lacrofill. We see a low tear meniscus height. No matter what else we see, I think that this justifies the use of punctal occlusion, lacrimal occlusion, not just the punctal entry, but the entire lacrimal system included with the gel. And then lastly, how many people believe us if we tell them we saw them not blinking when we're looking at the slit lamp? I'm going with nobody. But if you do blink analysis, you show the patient on video or with photos, you're not blinking. You're not blinking, and that's part of the problem. And part of the education is teaching them how to blink better or just getting them to do blinking exercises so at least they're blinking during the exercises. Next. This is something that is near and dear to my heart. I think the ability to show patients where they were and where they are is very important. I love the fact that we can do this and we can have grading scales on the screen for the patient to compare. I've long said that patients are way more concerned with eye redness than ophthalmologists and optometrists are. I think that's probably a failure on our collective parts. It's certainly a failure on my part. But it's a lot harder to not be impressed by the dryness, by the redness, when it's right in front of you as well. But having the ability to show the patient, this is where you were and this is where you are, is also a very important part of the cheerleading that we do to keep our patients on medications. showing them objective data in addition to listening to what they're telling us is one of the big deal advantages of BOSA. Next. There are different diagnostic protocols that you can set up. The brilliance here is that it's up to you. You choose. You decide how much or how little you want in each one of the protocols. We have a cataract protocol, we have a basic screening protocol, and then, of course, we've got our advanced protocol. We only need 3 in our practice, but you've got the ability to put together whatever works for you. Next. You can fit in whatever questionnaire you like. We like the speed test because we find that it gives us a better indication of who needs a procedure, whether it's IPL, thermal pulsatile treatment, BlephX, any treatment that a patient might need. We find that we identify them more readily with the speed test. But really, your mileage may vary. You might like the OSDI, you might like a VAS. The point here is that you can plug that in and use that as part of the report that BOSA generates for you. Next. I really like this. I'm really, really looking forward to some of the new things that the crazy mad scientists that work on BOSA have coming. But even with this, you look at it and you grade it, it's still better than anything else that's out there. You can show the patient where they are against the EFRON grading scale, and then you can show them where they've gone. I really, really like having that there, and it's a big advantage because it's not really enough for me to say, hey, you look less red. It's really impactful to say, hey, all the hard work you're doing is reflected in the fact that you're not as red. Next. And here's a place where you can actually do some billing. If you take external photography, it's the same thing as if you use a slit lamp camera. This is a very high quality camera. Collarettes are the big thing. We tell our patients to look down. If you see collarettes, you have Demodex infestation. If you see collarettes and it goes along with blepharitis, you now have Demodex blepharitis with or without ocular rosacea. And if they have symptoms, you should be thinking about how to treat that. Demodex blepharitis with recurrent styes, this gives you an opportunity to bring those two things together for the patient and say, this is why I want you to use, for example, Xdemvy, or this is why I want you to have BlephX followed by IPL. And then scurf, this is the classic thing that we see with both rosacea and staph. And I think Dr. Reineson will probably agree and probably talk about the fact that if you have something which prompts you to think about staph blepharitis, you want to get rid of the biofilm that the staph causes. And again, showing the patient is very impactful. And you've taken a photograph, and there's no reason why you can't bill for that. Next. You can take pictures of basically anything. You can take pictures of dendritic keratitis. You can take pictures of papillae, the capped glands with rosacea. I think we're going to see a lot of that in a couple minutes. And then, just to show the picture with their camera inlayer, what a scar looks like. It's one of the really, really highlights of BOSA in our practice. Next. And again, just some other examples of pictures that you can take. Next. And that the one on the top right is kind of cool. That's lissamine green with a herpetic conjunctivitis. That's kind of sharp. Next. I think that if you're going to buy one diagnostic instrument for your dry eye clinic, whether you're a comprehensive ophthalmologist or optometrist, whether you are a high volume optometrist referral center for cataract surgery, whether you are a cataract and refractive surgeon of any volume, if you're going to have one diagnostic piece of equipment that's going to drive your dry eye practice right now, I think the best single instrument in the market is the BOSA. There's competition. Yeah, you Hilco, M&S, Bruder folks, you got to stay on your toes, man. There are people nipping at your heels, but right now you still get the lead. And this is the one, if you're gonna buy just one, this is the one that's the most versatile in our experience. Cynthia, thanks for inviting me. Folks at Hilco and Bruder, I'm very flattered that you guys asked me to chat.
Darrell, that was really, really a well done presentation. You gave us so many um, reasons to consider integrating an objective diagnostic device like the BOSA into practices, whether, as you said, it's a comprehensive ophthalmology, optometry, or a tertiary dry eye center. And patients absolutely love seeing the data, love the color coded pictures that you share. It kind of makes it real to them because they hear what we're saying, but seeing it, like the adage goes, a picture says 1,000 words. And I think this falls into that.
I like to tell patients that I have a very visual specialty, pun intended, but the good thing about it is that they can see exactly what I'm seeing. And it's really almost self-explanatory. They see the collarettes at the base of the lid. They see the scaling and the telangiectatic vessels on the lid margin. They see the tear breakup time and things of that sort. And you want to do your explanation. They're saying, yeah, no, I get it, doc. I get it. What are we going to do about it? And it really moves the conversation along.
So, Darrell, I have one final question for you before we go to you, Dr. Reinerson. Have you found that once you integrated the BOSA into your practice, has the conversion to in-office procedures demonstrated an uptick?
So I'm not really sure how I can say this without sounding very self-satisfied, but we were really good at the conversion game before this. And a lot of that I actually, with thanks to you and your advice so many years ago, I think what this has done is it streamlined our process to where we're getting to that conversion point faster. And we're
Mhm.
getting the patient to the understanding that you have to make a decision faster. And we're
Mhm.
doing it with greater uniformity, with less deviation from protocol. And we still have a very similar conversion rate, which is really quite high, but we're getting there faster. And as you know, another way to drive revenue to the practice is to be able to get to that point with more efficiency. You're still only going to do what's supposed to be done.
Of
You're not
course.
you're not looking to do things that don't need to be done.
Of
But
course.
when you think the patient needs something and you show them the data from BOSA, they're already there before you go into your explanation. And it makes it a much more efficient process. I think if you struggle with conversion, I think that this would boost your rate to get patients to do what you know they need to do. They need to have BlephEx. They need to have thermal pulsatile treatment. They need to have IPL. You want them to have Lacrophil. You show them a low tier meniscus. This is what it's supposed to be. Here's you. There's just not enough water covering the sink. We got to plug the sink. It makes it a much faster conversation to go from you don't have enough tears to we're going to do Lacrophil as an example.
Got it. Well, thank you again, Darrell. That was excellent.